Okay, well, the people in the room got to hear my fabulous introduction of Dr. Saila-Ngita, which I'm not going to go into again, but we are very, very excited to welcome him and to give us a really great One Health talk today. Thank you so much for coming.
Thank you. Thank you. So thank you all for inviting me, and I hope you can hear me, those on Zoom. Three things about my background. One is that I'm a veterinarian, and second, I have a PhD in economics. But the third, I would say a great deal of my career has been in Africa. So that's why I'm talking about low-income countries, and particularly the DRC, which the country I love and I know very well. And working on different aspects of antimicrobial resistance. Sometimes people are not very used to deal with, to go beyond the lab, the molecules, the genes aspects. And when you start talking about other socioeconomic aspects of policy aspect of AMR, people get a little bit lost. And that's why I thank CIMAR for this invitation, so that will help us to discuss aspects that are not discussed on a regular basis. So why the talk about AMR in low-income countries? We've seen some predictions. People have said that it will be catastrophic, the future in developing countries. AMR may kill a lot of people. For instance, this prediction by the review of AMR in 2014, which predicted 10 million deaths by 2050, and 4 million will be in Africa. But also more recently, we have an estimation prediction by Murray, which believe that there will be around 5 million people may die, and most of them will be from the low-income countries. And WHO has recognized that socio-ecological and political factors are very important drivers for the antimicrobial resistance. If you look at the graphics, the model from Davis, 2010, you see how complex the situation is. The antimicrobial resistance, the drivers, it's very complex. It involves many sectors. And I believe that's why it's very important to have a systemic approach, to look at systems, how all these systems are playing together to develop the emergence and the dissemination of bacteria and that may cause resistance. But also, when you look at closely this model by Davis, you see that the human side is very small compared to the rest. It's very small. If you look at the animal side, and many people are saying that believe that the animal sector is one sector that is producing a lot of is very important in terms of AMR. And you can see in the food animals, you have a lot of species. And you can add to that the companion animals, you can add farm, or whatever comes from the farm. But another interesting thing here, besides this One Health approach, that requires the One Health approach to deal with this situation of AMR. One Health being defined as the collaboration across sectors to reach an optimum health for human, animals, and the environment. But also, more recently, people are also talking more about the eco-health, which is very often forgotten. The eco-health is about looking at the environment, how the environment affects your health. And these two concepts are being more and more brought together. These two concepts, they used to be apart, but more and more people are trying to bring them to deal with them together. Months ago, I was in Singapore at the 7th World One Health Congress. It was brought to the attention to many people that the environment sector is not being involved in that process very much. so that we need to bring the environment. It's more human focused. And even if you look at this model by Davis, you see all arrows focusing on human sector. And that's what some people are calling these days the egocentric model, where here humans are put at the top and everything evolves around humans. But other people believe that it has to be more eco-centric, where we have to put more emphasis to many other sectors. And so that even looking at this model, you see that it's very complex. So if we don't look at it through various angles, it will be difficult to really come to get to the solution to this problem. And when you look at it in terms of the low-income countries, they have different challenges that needs to be taken into account if we believe we can solve the problem with this public good, which is the antibiotics, the antimicrobials. So I'm going to recognize colleagues I work with in this research since my first interest in this came, I was attending a webinar, and the presenter talked about open defecation and developing countries as very critical. And since that time, he was talking about Africa and being very involved with Africa. And my interest started there to look into this thing to see how really Africa, these developing countries, low-income countries, their role should be what's going on and how it affects the whole phenomenon, the whole endeavor in terms of controlling the antimicrobial resistance. So these are my colleagues I work with from the University of Kinshasa, but also from University of Witwatersrand in South Africa and Université de Liège in Belgium. So my presentation, I'll have three components in my presentation. First, I'll talk about, present a global perspective on the DRC. Second, I'll talk about governance of pharmaceutical sectors. And also I'll talk about a proposition for a solution in the animal sector. So those will be the three focus of my presentation. So for those who don't know DRC, that's the biggest country in the center of Africa. That's the Congo Basin, a very tropical area. Congo is the second largest country. It used to be the third largest country, but since Sudan was divided into two, it's now the second largest, with a population that has been growing at more than 100 million people. In terms of area surface, you can see the second map below. You can see that DRC is about 3 times the US. It's 5 times France, 80 times Belgium, to get an idea of the size of DRC. As the picture shows here, you have it's a beautiful country, really. It's a very beautiful country, and I had a chance to travel across that country. From the northeast, that's a picture from Kisangani, the northeast of the country, beautiful. And the very dynamic life in the capital city, Kinshasa. And you all invited to go visit. Because I'm going there tomorrow, so people say a lot of things, but I'll be there tomorrow. I'm going there tomorrow, so it's safe. But also, if you look at the map, you will see we have 9 border countries bordering the country, which is a bit challenge in terms of security. And the country is very rich in terms of natural resources, minerals. But it has been in a very difficult situation politically since basically, I would say a long time ago, since even the Berlin Conference. Many of you may not know about the Berlin Conference. It's a conference that took place in Berlin, in Germany, and that divided Africa into countries and different powers. So the leftover of those discussion or conflict at that time, people are still facing them today. So the country became independent in 1960, but we have persistent degradation of the rule of law, which has a significant impact on health. So here is an example to show how the situation, the health situation has been deteriorating. The picture you see with pharmaceutical, with tablets and That picture is from Haiti, it's not from Congo. But we used to have the same situation in DRC. Everywhere in Kinshasa, you can see people from drug peddlers in the city, but we don't see them anymore. It's very rare to see. That's why I took a picture from Haiti. Otherwise, I would have taken a picture from DRC. But what happened that the people used to sell these drugs now selling different things. Like you see here, these are products like cola nuts, bitter nuts, and other traditional products people use. And most of them have properties of aphrodisiac, and that's why they are selling them. But another thing you can see here, so there is a change from pharmaceuticals to these traditional products they are peddling on the street. And you can see another thing here is that we have cigarettes. DRC has had cigarettes, very stringent rule for importing cigarettes. And many of these are foreign brands. And the rules have never changed, but you can see people are now peddling cigarettes, foreign cigarettes on the street, which means the people are not upholding the rules anymore. That's an example that I put an example for that. But what's happening, those who used to peddle these drugs are now established in a small shop outlet, pharmacy outlet, you can see there, and creating very small health clinics, and many of those are not regulated. So the sector that used to be regulated is now becoming an informal sectors, not regulated, difficult to control, and they are selling drugs the way they want to do that. If you go back to this picture, you will see on the top of the woman carrying that basket, you will see a pair of scissors. Those are used to cut. So they even don't have to sell the whole dose which is prescribed or you want to take. You buy by the way you buy, as they call in French, they say by the taux du jour, you buy as you based on your pocket that day. So if you need 7 tablets, you may buy them every day. You know, you buy one today, one the next day, one the next day. You can imagine how, and some of those are antibiotics. And you can see how people are using antibiotics, how it's because it's very difficult. Now, this has been moved to now people are establishing themselves in small shops, outlets, because there is no control basically. And then nobody will come to bother you if you open something which is not officially open. So these are the situations you can see, and so there's kind of a deterioration the way the rule of law is being observed. But another thing is that we need a picture in the middle, you have a depot pharmaceutic. These are wholesalers. There are many of them now. They import drugs from many countries. I'm not going to name names here. They import drugs from many countries, and they have now people buying from them as a wholesaler, those small shops and small pharmacies. So the regulations are not upheld, and you can imagine we're talking about pharmaceutical in general, but antibiotics are part of that process as well. So we are moving more into an informal sector. If a sector 25, 40 years, 30 years ago was very controlled by the government. And that's an issue, political impact on the way antibiotics are being managed, being protected. Now, if you look at how DRC is performing in terms of the infrastructure, in terms of the policies that are being put in place to under the different efforts through the United Nations and other international bodies. Back in 2005, some of you may know that the World Assembly decided to approve or accept the International Health Regulations, the 2005 version, which entered into effect in 2007. But 3 years later, they found that many countries were not able to put in place the requirement of the International Health Regulations. So to help those countries, only 30% were up to date at that point in 2007, 2009. So many countries, entities came together and put together the Global Health Security Agenda to provide resources and support for those countries that were not able to put together those requirements from the global health, the international health regulations. So in that effort, the purpose is to prevent and reduce the likelihood of outbreaks detect threats, and respond more rapidly and more effectively to disease threats. But only among the technical areas of global health security, we have antimicrobial resistance. It's one of the 19 fields where the global effort is being put together. So many efforts are in place to help countries to do this, to get up to date. So if you look at the performance of DRC, that was evaluated in 2018. DRC didn't do well. DRC score was 1, basically in all indicators, and we have 4 of them. You can see on the top. We have 4 indicators. I don't know if my cursor is indicating where on the big screen as well. So the first line you can see, and that's a system of scoring, a 5-level, 1 to 5 points, and with colors. 1 gives you the red color, 2 and 3 gives you the yellow color, and the 4 and 5 the green. And there are things you have to achieve to get to that level. 1 means that you have no capacity in those indicators. And one of the indicators on the global health, on the GE, the Joint External Evaluation, is antimicrobial stewardship activities. So here we have 4 indicators. The first one is antimicrobial resistance detection. So you need to have lab capacity. Surveillance of infections caused by AMR pathogens. You need to have a surveillance system in place. Healthcare associated infection prevention and control programs, the ICP. And also you have to have stewardship to see how people in the community and everywhere, the whole industry is functioning. So DRC here scored 1 at all these levels. So you need, for instance, to move to level 2, you need to have at least a plan, a national plan has to be established to move to the next level. So DRC has a long way to go, and from there, a lot of effort should be done. But this was done in 2018, and I don't believe the country has put together a national plan at this time. I haven't heard about it. So if we have to spend 4 or 5 years to move to the next degree, you can imagine it would take DRC, what, 20, 25 years to get to a green zone. Many of us will be in retirement at that time. So key points we have to take away here is that we know the growth of the informal sector is a problem, and for social, economic, political reasons, this pharmaceutical sector is more and more unregulated, and which is a bad thing. Progress is difficult to sustain without improving the socioeconomic fundamentals. It's a development issue, the way I see it, because no matter how much money countries like US, Canada, and Europe, EU can put in supporting these countries, they have to help themselves. They have to have the means to help themselves. There will be no enough money to do that. And I see in programs we are running, like the USAID programs, they may put $1 million in a country, but that's nothing. All people may provide, countries may provide 40 million. It's nothing for a big country like DRC, that's nothing. So the country have to be in a position where they can handle these things by themselves. So the health sector is really deteriorating because of the geopolitical situation. And there is a need for comprehensive solution beyond the surveillance and the molecular studies. So we need to move from the lab to the community and look at how everybody is playing the role around AMR. We need to mitigate the risk factors. If the country still live in poverty, it will be difficult. And as we know in public health, they say that the economics plays a role, because if people in the poverty has a tendency to have more infectious diseases, and those with a high income, they have non-communicable diseases. And that's how the burden is distributed. So universal coverage is important, and that's key. Now let's look at the second aspect of my presentation. Let's look at the legal regulatory framework and what actors, the behavior of different actors, and the practices and their perception. We did a study on that in Kinshasa, and that allowed us to understand a little bit. It was a qualitative study to get a little bit more understanding of this system. I think qualitative methods are very important here because they help you to go deeper in the situation to understand it compared to more quantitative methods. So the objective was to describe the legal and regulatory framework governing the pharmaceutical industry, identify actors and activities responsible for emergence and dissemination of antibiotic resistance, and also assess the knowledge, the knowledge and the practice of these those involved. So as I said, it's a semi-structured interviews and focus groups were used, and in-depth interviews of various actors, and also direct observation to look at how they discard their waste, how they manage waste and those kind of things. Because all these things, as you saw in the first model, in the first slide, all is connected. So we had about 349 people we interviewed, and we worked on a neighborhood of Kinshasa, which is we call peri-urban town. It was a mixture of rural and urban environment with poor people, livestock, and all the mixture. So let's look at the legal text, legal documents, and regulatory document text that's governing the industry. We'll look at it in terms of imports, in terms of drug manufacturing, and in terms of distribution of medicine, and see how people are upholding the law, the rule of law, and how they are violating those requirements or regulations. So in terms of imports, myself, I've been involved in drug registration in many African countries, Nigeria, Uganda, Kenya, Mozambique, DRC. So when you look at it across different countries, they are different. There are a lot of differences. Some countries have very good systems. They control, you go in with a new product, you go through a process like what the FDA does in the US before you put a product on the market. But other countries, it's very easy. It's easier, I would say, compared to the other countries. So it varies a little bit. But in some, in DRC, we looked at those regulations and see where people are not respecting the law or the regulations. For instance, when it comes to, we have two main decrees, one from the Prime Minister, 2009, and the other one was in 2015. The first one determines the condition of drug importation, what you should have to do if you want to import the drug. And also, it requires a license to import pharmaceuticals, and antibiotics are also included. And also, it requires an authorization to sell. So all these are regulated, like in many other countries. And these rules basically were just rules that are run because Congo is a colony, a former colony of Belgium. So they use basically the same regulations they have in Belgium. So you cannot just import a drug and then put it on the market. You have to make sure that you have to understand that the company, the lab that produced that drug is qualified to produce it. Their processes are validated. And then also they have to send you different documents and samples that needs to be tested from the origin country and also locally. So the whole process is in the book. And before you get a license to put your drugs on the market, because there are a lot of counterfeit drugs and which are also creating a problem. So if a country is not, it doesn't have the systems to verify if what the quality of the drug coming in, it creates a problem. And we have that in many of these developing countries, and DRC is one of them. But the importers, they believe the system is very cumbersome because you have to go to different offices to get papers. And very often, by the time you get to the last office, they may tell you that paper, you have to get it in 30 days from the first signature. And by the time you get to the last person to sign off, you have gone beyond the 30 days because someone in the process was not acting very fast. So they complain about those things. And also, so they are importing without using the proper documents. And also they tend to use different ways of going around the law. But that's a clear problem as well. You know, that's not only in pharmaceutical, even just want to import something in DRC. the process is very cumbersome. But if the person who has to check the documents is willing to take some money from you, then you can see why people don't care about really about the law. The second one created the Congolese Bureau of Standards. It's like an FDA office that is in charge of controlling testing in the lab, the quality of the drugs when it comes in. So by that company, if they have good labs, they can do a good job. But unless the product goes through the process, you cannot guarantee the product when it comes in the country necessarily. So, but also they have the cost, what you have to pay to get your product in seems to be too high. The duty is more than 50% in DRC, basically on everything. So even pharmaceutical, they still charge very high duty on those. And that increases the cost to the end user, but also it's just the cost someone in a small operation cannot sustain. And if he has an alternative to beat the law, he is more likely to do so. So all these little things and policy administrations have to be aligned properly so that we can avoid this kind of situation. The second thing to look at the manufacturing, we have also laws governing that sector, and some of them were put in place in 1933 during colonization, and they're still in effect, like the decree by the governor at that time in 1933. It defines how, if someone wants to manufacture, we have some manufacturing companies in DRC, but they are not producing antibiotics, they produce other drugs. So the rules are such that you cannot import excipient or different products you're going to use for your production. There are the same rules you have to follow. They have to know where it's coming from, the quality, and all the regulations have to be followed, and who can do that. So all those are well reported, well governed, well defined in the laws that exist. If you look at the distribution, where we have a lot of problems, in terms of manufacturing, it's not very difficult. Well, a lot of problems there because the companies they are big companies, and it's very easy to control them. But when it comes to dispensing or distribution, that's where we have more problems because we have a lot of small shops, and the government doesn't have the resources basically to go everywhere to control everybody. Okay, that's a message from Rima. Okay, so in terms of the distribution, we have the presidential decree of 91 that determines that you need to have a pharmacist in an outlet, in a shop pharmacy. So you need to have a pharmacist so you can guide the process. But we need that law is not really being, many of these shops I show, the picture I show, they don't hire pharmacists to be there to guide the process. Basically because also how much money they make in those small shops to survive for themselves, the owner of that shop, and then to pay someone with that benefit. It's totally minimal. You can't do that. But they play a role in the city because people need drugs. So they have to be there. People like to go there to get their medicine there, but they can't afford a pharmacist there. It's just the benefit is not there. The profit margin is not enough. So except that the wholesaler, they have a mandatory, they have to have a pharmacist, because also the pharmacy council follows that. They want to have one of their own to get a job in that wholesale operation. So it's mandatory before you open a wholesale operation, you have to have a pharmacist. So there usually the rules are upheld. But also we have mayors, they don't have the authority to issue these documents, but they are doing that. Because only the Ministry of Health is allowed to issue the papers to open a pharmacy outlet. And there's a requirement for clinical trials when you bring in a new molecule, the process is in place. We don't have many violations in that area. but the logistics of the government is not there to start controlling everything. And also people don't know about the regulations. So even those working in the government are supposed to be maintaining the rules of law, but they are not aware of all the details of these regulations. And of course, some of the people who knew how to do that have retired, and the new generation is not well trained, prepared to take over. So that's also a factor. So these laws have to be, they've been there. Some of them probably need to be updated, and they have to be harmonized between the human and animal sector, because when it comes to importing animal drugs, the Minister of Agriculture does it, but the law says that it has to be the Minister of Health, which has a division in charge of that. But between the two sectors, they never agree. So each of them is issuing the permits for imports, and it creates a lot of confusion. And the Minister of Animal Health doesn't have the capacity really to control these things. But that confusion between sectors is a key. So we need to harmonize in that area as well. In terms of behavior practices, we have here the two columns shows you what households do and what farmers do as well. Basically, in both areas, they do the same thing. They are auto-medication. If you have animals, you're going to treat them yourself. You don't want to call a veterinarian because it's too expensive. And also you can buy your antibiotics directly from a pharmacy. So why pay money to bring in a veterinarian instead of doing that yourself? Or you see the first time when you come in, what you did the last time, and the next time you go buy the drug yourself, you do it. And for humans, the same thing. People auto-medicate for many reasons. Some people, they will tell you that if I start feeling some symptoms, what I do, I pop some antibiotics just to avoid getting sick. So antibiotics in humans and in animals are being used as vaccines. We know that in the fall, we have, you lose many of your pigs. So what you're going to do in the beginning of the fall, you have to inject them with antibiotics. Even if that's a viral disease, that's killing pigs, but you have to do that. So we have those type of open defecation. The problem of maintaining sanitation around where people live is also a big problem. Management of waste. All systems are managing waste. If you see a slaughterhouse, you produce good quality meat, but while you're doing this, also you are producing waste that needs to be managed. And usually from farms, you have farmers that are using antibiotics, but they kill the animal just right after injecting them. They don't respect the withdrawal time, because you cannot inject antibiotics and then bring the meat to the market at the same time. There are some delays per period of time you have to observe. So many of these farmers, but for farmers, they are not aware of that. The animal is sent to the slaughterhouse and it's on the market with residues of antibiotics. So there is a problem of awareness in all these areas. But also we have, we see that those problems everywhere, even those in the gardener, because all these systems, particularly the waste system, is well connected. We have people, like the picture shows there, market gardeners. They produce vegetables and they go sell it, but the water they're using may be coming from a farm or a farm, livestock farm, where people are dropping manure in the river, and people downstream are using it for their operation, agricultural operations. So the whole system is connected, and that's how we have this different behavior. And practitioners are in many cases not well trained, so we have those issues. So awareness is a big problem. The income of people, poverty is another problem. Managing waste across different sectors, animal, human, is a big problem. So if we want to resolve the issues of antimicrobial resistance, we need to look at those issues as well. Another study we did was the question we're asking ourselves, whether we can use veterinary vocational schools as hubs from where start operations to teach people how to to treat their animals, how to avoid mishandling antibiotics because these schools are basically everywhere in the country. We have, in the DRC, we have 9 vet schools, 103 medical schools, of which I spoke with the president of the medical council. He told me they only recognize 58. We have 3 pharmacy schools. They have a lot of nursing and vet technician programs. But these vet technician program and nursing programs are everywhere in the country. So we thought that if they are well scattered in the country, they could be hubs from where we can start activities for antimicrobial resistance. So we use the qualitative method and also a SWOT analysis of those schools in the province close to the capital city, the Congo Central province. We interviewed about 17 out of 35 of those schools. And what we got there is that all those schools are funded by the government, but they are not all up to standard. The curriculum of veterinary technician is a 4-year program. Many of these schools don't have qualified teachers because to teach clinical courses in those schools, you need to be a veterinary doctor. And many of the people teaching there don't have the degree, and that's a problem. DRC have a lot of veterinarians that can teach, but many of them don't want to go work in rural areas. So the veterinary practice in those areas are left to veterinary technicians who are not well qualified to even not allowed to dispense antibiotics. But they are doing this because there are nobody else to do it. And if you stop them doing this, who will be treating animals? And then those animals will be sick, there will be economic problems. Even the human side, if you don't allow everybody with even no degrees do that. So if you stop it immediately, you may also end up with people not getting the care they still get at this point. So it's a tricky problem, a tricky solution. But we thought that we can work with those schools to be able to start those operations, interventions. They have some strengths because they have the mandates to do those things. They have some weaknesses, they need investments. And the opportunities that AMR is at the forefront of activities these days, so they can get some resources to do that. But the threat is that they have to be participating, that to take the train as this moving train. Otherwise, they may lose the opportunity. So we have overuse of antibiotics in those areas of school. Basically, the same problems we enumerated before. Some are still using antibiotics for growth, which has been banned in the US and Europe. They use antibiotics as vaccine, but they also, many of these practitioners, they use the internet, which is good because you can train them if they are already used to connecting to the internet to get information. This is good. So that can be used for giving them more information. In the vets, animal health, they don't have algorithm guidelines to treat some diseases, how they can efficiently use the antibiotics for different diseases. So that is missing. So those are things that needs to be addressed. So we believe that vocational schools can promote antibiotic stewardship. Faculty can be trained and supervised to collect data and information. They can be part of a surveillance system, but they don't have the leadership to do these things by themselves. We need people to help them play that role they can well play. Of course, some of them don't have the infrastructure they need. They will need some resources to do that. So overall, we need the solution to AMR must be multi-pronged. You cannot just address it by surveillance at the hospital or detecting the genes at the lab. We need to involve all sectors. It's very important to do that. We need a comprehensive national plan for antimicrobial stewardship, and we have to avoid the implementation of policies that could also generate unintended consequences. Thank you very much.
Thank you so much. That was a great talk. Should we take a look at the chat to see if there are any questions in the chat? So I actually have a question for you. So As far as,
This is-
this is a very practical question. So when you go and do your work, and you do these interviews, who do you decide who to talk to? Like, how do you identify the stakeholders and?
Yeah, I mean, we started that study, we started with government people from different ministries, Ministry of Health, Ministry of Agriculture, Ministry of Livestock.
Mhm.
And then now they gave us their perspective. And then also they suggested who are the stakeholders, the actors involved based on their understanding. And then we started from that list that they provide us. So we started with government, different sectors.
And how do you, so how is it talking to people who are looking at the legal ways of bringing antibiotics into the country or prescribing antibiotics? And how do you encourage the dialogue when it could get people into trouble?
Yeah, well, yeah, that's a good question. In 2010, when I was still part of USAID Emerging Pandemic Threats, I initiated what they call the FUS, Fédération Une Santé in DRC, which is a consortium of all of the Medical Council, the Pharmacy Council, the Vet Council, and the Nursing Council. So the three, they have been working in a consortium, so they can discuss issues that is of interest to everybody. Of course, you have to have the IRB approval, and the IRB approval, you have to guarantee that the people you interview are not going to, their identity is not going to be on the street compromised.
Okay.
Yeah, so those are, we respect the IRB. You have to get the IRB approval. So through the IRB, you know how to maintain safety and confidentiality of people you are talking to.
I was thinking more in terms of how you actually find people to talk to and how you know, because people there can be informed consent, but there's also sometimes a lot of suspiciousness still. So anyway, it's just an incredible problem, and it's a wicked problem that needs it's a complicated solution. Does anyone in the audience have?
In human medicine, obviously telehealth is becoming more and more common, and I wondered whether there could be a role for tele-veterinary medicine in a case like this, especially to access rural areas.
Absolutely. I believe in technology. In 2004, I was at Columbia University at that time. We were running a program from CDC for information management system, which was to use, how to use the telephone and also the internet. And that was the first program really from CDC in Africa, Sub-Saharan Africa at that time. So it was interesting to see how we put it together for the human side. It was for HIV, and then now it has been one of the best in Sub-Saharan Africa, in Rwanda. So I believe in the using the real-time system, the internet, to do that, and it's very possible. That's what we want to do, and the applications to do that easy to put in place these days. And even our current programs of Stop Spillover, there are some countries like Bangladesh, they've proposed to use that. Even our colleagues in Uganda also are proposing that, how you can use a telephone to connect, because in many of these places they have access to internet, access to telephone is very easy now. I recall in 2004 when I was in Rwanda, the coverage was about 45%, but Rwanda, of course, is a small country. Now they basically have 100%. Maybe only in the national parks they don't have antennas, because there are some regulations, environmental regulations. Yeah, so it's very possible.
Thank you very much for sharing that with us. I was sorry if I missed this, but is there any regulation on keeping antibiotics for animals versus humans? Like any sort of distinction between the prescriptions between?
Yes, I mean, the 1933 decree wants those two to be separate. But in the field, people are using, you know, if you are a farmer you are more likely to have access to a pharmacy selling human drugs, and they use that. But the difficulty they have is how do you do the dosage? Because they rely on the label. On the label, it tells you the withdrawal period. You have to wait 28 days before you eat the meat. They tell you how the dosage for animals. But when you buy a human medicine, of course, the same molecule maybe probably, but they have difficulties in dosing, coming up to with the right dose. But they still do.
And do you have,
Particularly for chicken, they do. They buy some tetracyclines, they put in the water.
so do you have is that the general practice? Like, is that the most widespread way that animals are getting their antibiotics, or is it just regionally different?
Mostly, no, they depend. I mean, it just depends on where you are. Some areas like the Kinshasa area, that's the capital city, and going maybe 300, 600 kilometers from there, you'll find some people selling drugs, antibiotics and other drugs. But usually, and also usually because the distribution is not very efficient, so you use the antibiotics you have, no matter what case you have, what type of pathogen you have. You use the antibiotics you have on your hand. So that's also is a problem. You can't decide which antibiotics based on gram positive, gram negative. Those things you can't take them into consideration. You just use the one you have. And that's what it basically, and that's also a problem because that's not proper management of drug. Yes.
A question in the chat.
Oh, maybe you can use this. Go up.
Yeah, go up.
Which one? This one down?
Yes, do you have community groups involving citizenship that are interested?
Yeah, not only community groups. Yes, some people are organized in cooperatives, and those can be reached to help them provide information. Usually, they do that. They organize themselves to a facility to buy. For instance, if you are 600 kilometers, you cannot go to Kinshasa just to buy whatever you want to buy, maybe a couple of pills. But if you organize as a group, it's much easier. You reduce the cost, you spread the cost. So those exist. Those associations, and they do that also for marketing. They organize themselves to sell, and then they have more power. When you organize yourself, you have more power. Yeah, and they're also very easy to organize. No, I think the awareness is not there yet, because even when you're talking about with professionals, they don't really realize that, and then that's how they use the thing, I have a colleague professor there. He said he had a dog and the dog was sick, and he called the veterinarian who came, just gave the dog antibiotics. If nothing else, just gave. I said, but it worked. The dog stood up and everything. So that's how it was. So there is no awareness to the point. And I was in a webinar 2 weeks ago. It was a UK webinar where they were talking about some disease, skin disease on the dogs, and different categories you have, at what point you should use antibiotics. They were saying out of 4 categories, you can use it only on the 4th category. But many people give antibiotics the first time in the first encounter. So. So, yeah. Yeah.
Apologies, the Zoom audience can't hear.
Sorry, this is not our regular room, so I apologize. I was just saying that that the first CREs reported in the US were reported from a pig farrowing to farm, to the point of selling them. And they treated all of their piglets at 2 time points, one when they were born and then one when the males were castrated. And this was the first farm where CREs were found. I think it was in New Jersey or Ohio or somewhere like that. So anyway, anyone else have any questions in the room? I'm going to do this right this time.
Hello, my name's Yvonne. I'm from Cameroon, so this is really interesting learning about Congo. So thinking about the different African countries and how they did in their scoring, I know the DRC scored a 1. I wonder what can we learn from other African countries that have pretty similar socioeconomic statuses and how they are championing this AMR.
Yeah, one thing I have to say is that these GEE joint external evaluation have been challenged recently because, as I said, many of the countries that were up to speed in terms of these different areas of the international health regulations, when COVID came, many of them didn't do well, but they were scored very high in those evaluations. How other countries are doing, it depends. Some countries are doing well and others are not doing well, particularly those with a lot of political, economic situations are not doing well. But also it varies because I've done, as I said, I've registered drugs across many African countries. You see differences. Uganda was, at that time they had their reform. It was pretty good. Yeah. So, but I know DRC has a problem. Nigeria had some issues, but they had a pretty good structure in place. So it varies. Normally, if you have to look at the health security index to see, and those countries not doing well on the health security index also not doing well in other evaluations.
There's another question in the chat. I know there's 32 people in the chat. So who make up the AMR surveillance stewardship? Are community people involved?
That's a problem here because when the Ministry of Health puts together these committees, normally they are not invited. And that's a problem. I think that's something we are trying to do and Stop Spillover. We are putting together these, and I think the person who asked the question is Vivian Kilema from Liberia. So what we are doing, that's the reason of bringing the community people in this working group we are putting together. Because usually when you organize a working group, it's some people from the ministries, and usually even central level people. People at the provincial level are not really part of the discussion, and which is a problem because they have very specific issues they have to raise. So unfortunately, the community people are not, awareness is not there. So we need to bring, I think that's a key as well. Awareness is a key. People have to understand that that's a problem. You can only act if you understand that that's a bad thing. Yes.
So you're talking about a problem in the Congo, but this has been a problem like all over the planet, right? So England realized that there was a problem with dentists giving out antibiotics willy-nilly, and they had a campaign. They made these beautiful posters saying no amount of antibiotics can cure a common cold. They educated people. They just had glossy posters, and they had a campaign to try and reduce the amount of inappropriate antibiotic usage, and also animal industry use of antibiotics. So you just need glossy posters. You need to educate the people. You need little statistics that are easy to understand, and then put murals on buildings and just let them know. They just don't know.
Yeah, that's one thing I agree. But however, you have some other things we have to understand. access to those antibiotics if the quality of the antibiotics you have access. So you may be a good doctor with all the knowledge, you may be prescribing a bad antibiotics, which was created in the backyard, in the garage, someone's garage. So no matter how your knowledge of medicine should be or capacity should be, but you'll be prescribing a wrong product. Or you may have a good product, but it was kept in wrong, good and bad conditions. And that's why you'll be using with all the knowledge you may have, but you'll be using a bad product. And we have some other people because they cannot afford it. Maybe in terms of cash or in terms of distance, the next hospital where you can get good care is too far. So it's very complex. It's a very complex situation. So
Thank you so much for, I know you're flying out soon, so thank you so much for coming. Maybe we'll hear you at some point because we also know you're the co-lead of the USAID Stop Spillover. I'm not sure why you're flying out today to Kinshasa, but maybe we'll hear
it's a
more about
holiday
that.
season.
Is
That's
that what it is?
Yeah,
Okay.
it's holiday season.
Oh, so you're going for holiday. Oh, good. So maybe you'll get to go to some beautiful places. So thank you so much. We are setting up a room upstairs. If anyone wants to join us for lunch, there's going to be a table with distance between people if you'd like to join us for lunch. So please come upstairs if you'd like to. Anyway, thank you so much.
Thank you. My pleasure. Yeah, thank you.